Good evening, everyone. I'm Dr. Ahmed Shoaib. Today, we are doing a session on behalf of Association of Pakistani Cardiologists, UK. It will be on intravascular ultrasound and OCT. Our speakers are Professor Javed Ahmed. He's a professor of cardiology in Freeman Hospital, Newcastle, and Dr. Javed Iqbal. He's a consultant interventionist cardiologist in Sheffield Teaching Hospitals. We have a great expert panel today, Dr. Suhail Q. Khan. He's a consultant interventionist cardiologist in University Hospital, Birmingham. Dr. Farhan Shahid, consultant interventionist cardiologist, Freeman Hospital, Newcastle. And Dr. Shazia Hussain, consultant interventionist cardiologist, University Hospital of Leicester. It will be interactive session, and we'll first start from the Professor Javed Ahmed, who will deliver a talk on intravascular ultrasound. And after that, it will be OCT by Dr. Javed Ahmed. First few things for housekeeping. We will launch a poll in between, and expert panel will comment on it. Secondly, we will give a link where we can share feedback forms, and after giving the feedback, people can get the certificates. Can we start now? And I can hand over to Dr. Javed Ahmed, Professor Javed Ahmed. I'm stopped sharing my screen now.
Can you make the screen full, please, Ahmed?
Yeah, I'm stopped sharing, and you can go for your side now, from your side.
Ahmed, thank you very much for inviting me to deliver a talk on intravascular ultrasound. I'm grateful to APC and very elite panel members, including Suhail Khan, Shazia Hussain, and Farhan Shahid. And my talk would be on different aspects of intravascular ultrasound. It is a huge topic, and it would be very difficult to cover everything. But I will try to obviously start with the basics, and then after that, we can have some case discussions on the basis of case histories. And intravascular ultrasound is a catheter-based invasive imaging modality that has become essential adjunctive tool to PCI over the last 20 years. Even though there are many uses of intravascular ultrasound in the catheterization laboratory, however, I feel the interventional cardiologist has two fundamental questions to make a proper decision when performing PCI. The first of these questions is the lesion which we are all going to treat is significant and ischemia producing, and therefore should it be treated? And the second question is, has the PCI been optimized after you have decided to treat the lesion? So after that, I will start with some basic information on the IVUS. So there are several modalities which can actually help us to image the coronary arteries and stenosis. There's a wide variety, including echocardiography. I mean, that is not exactly meant to image the coronary arteries, but during the echocardiogram, one can actually assess the coronary ostia. CT coronary angiography, we are all familiar with. Optical coherence tomography, intravascular ultrasound, and some form of MRI scanning and perfusion scanning. So what are the limitations of a gold standard coronary angiography? The projected silhouette of the lumen is not adequate. It can underestimate or it can overestimate the stenosis. And the whole extent of coronary atheroma cannot be visualized because it's a two-dimensional luminogram. And also the curvature in the artery and in homogeneity of the plaque distribution throughout the artery makes it quite difficult to look at a two-dimensional image of the coronary artery of a structure which actually is three-dimensional. And also lumen eccentricity sometimes plays a part as well. So how does IVUS works in actually increasing our knowledge about not only the atheroma distribution, as well as some form of measurements which we can perform during the procedure. Intravascular ultrasound transducer rotates and pulls back through an area of interest, and it emits sound waves. Multiple pullback speeds are available in majority of the intravascular ultrasound machines nowadays. Sound waves are reflected or passed through different structures dependent on the density or acoustic impedance. And Polaris system is one of the new system where the transducer is rotated and thus transducer produces the imaging. Can I get rid of, how can I get rid of this sidebar so that?
You can go top share.
I got it. Okay, that's fine, yeah. So what types of intravascular systems are in clinical practice in cath labs at the moment? And there are two basic types. One is the mechanical system, which has got, as I mentioned earlier on, a rotating element. And there is a single transducer which rotates at 1800 rotations per minute to generate a good quality image with high resolution. The second system is electrical or electronic system, or the correct word for it is a phased array system, which has got a multi-element array of literally wires sitting in a catheter, and these has got multiple transducer elements, which actually combine images to be relayed back to the computer. And the only problem is that it has got low resolution compared to the mechanical system. So this is just an example of phased array system. And you could see that on both, on the right hand side is a mechanical system, which produces slightly more clear or crisper image compared to the phased array system, which is on the left hand side. So how can we interpret the IVUS grayscale? Grayscale basically means black and white. And I think we use a lot of this grayscale term in the cath lab. Grayscale is either black or white, and compared to OCT, which is usually colorful. And there are three main types of plaques. And we all know that atheroma is full of fatty tissues, and this fatty type of plaque absorb more of the ultrasound and it actually usually appears dark. Then there is a fibrous tissue, which is more echogenic. So the more fibrous tissue content in the plaque, the lighter it will appear on the grayscale. And then there's a calcific plaque, which reflects ultrasound waves and appears white on the ultrasound image with black shadowing behind. So the basic rule is if you see a very bright arc in the artery and there is no shadow behind, it is usually due to calcified plaque. This is just an example of, on the top panel, it is a fatty plaque. In the middle panel, it's a sort of fibrocalcific plaque or fibrous plaque. And in the lower right-hand corner, it is a calcified plaque, which is quite severe calcification, almost a 360 degree. This is what vessel anatomy looks like on intravascular ultrasound and also on the histology images. The most outer layer, which is the brightest of all, is called adventitia, and it has sheets of collagen, and that reflects a lot of ultrasound. That's why it appears the brightest of all the three layers. Then there is a thin rim of black, shadowing, and that is made of homogeneous, smooth muscle cells and does not reflect ultrasound. That's why it appears dark. And the inner layer is intima, which is the plaque is dense and will appear different shadows of white. And this is the thinnest of all the three arteries, so all the three layers of the artery. As we all know that the diameter of intima has to be more than 250 micron meter for it to be visible on intravascular ultrasound. So this is again another image showing the different layers of the artery, but this time it is also showing that number 4 is the blood speckle, number 5 is the hollow around the catheter, and number 6 is the dead space, and that is the catheter itself, which is the ultrasound catheter. And then different landmarks. Again, the catheter is in the middle, and then there is a wire artifact, and then there's the blood speckling, and then there's the endothelial border, and then this is all lumen, and then there is atheroma and adventitia, which is the brightest part on IVUS, and then there is a side branch where my cursor is. And this is just another example and of artery which is healthy, which is on the left-hand side. And then there is an example of the artery which is diseased. And you could see that there is almost a concentric plaque, more of a centric rather than concentric. And that shows very small lumen. So this is the diseased artery. On the left-hand side is a healthy artery. And the next one is an example of a soft plaque. This is not as bright as the adventitia, and the soft refers to the low echogenicity, generally due to high lipid content in a mostly cellular lesion. And the next one is fibrotic plaque, as bright as or brighter than the adventitia. That is a good way of picking up when you say a plaque is fibrotic. It usually is quite bright, and you can actually compare it with the adventitia, and that you can confidently call it a fibrous plaque. And the majority of the atherosclerotic lesions are fibrotic. They're very dense. Fibrotic plaques may cause so much acoustic shadowing that they could be misclassified as calcified lesions sometimes. The next is how do we do the measurements of the calcium? Calcium is quantified by measuring the arc it encompasses. And we start with an arc of 80 degrees. And if it occupies 1/4, and if it occupies half of the lumen, then it is 90 degrees. And if it occupies the full lumen cross-sectional area, that is 360 degrees. And then calcium is classified by its location within the plaque. It could be either superficial or deep. The simplest way of recognizing is that if the superficial calcium is closer to the lumen than to the adventitia, the deep calcium is closer to the adventitia than to the lumen. I think you could see that there's a lot of calcium in the second image, and then you can see in the bottom 2 images that there is deep calcium which is close to the adventitia, that is away from the lumen. And now there are some form of other artifacts during image interpretation. You can see this is these reverberations are due to guide wire, and sometimes if you inject too much air, particularly with a mechanical system, then you could see these this type of image. And this is the plaque, and this is the blood speckling. And next is another problem sometime with the catheter. which is called NURD, N-U-R-D, which is non-uniform rotational distortion. And it is mainly due to if there are any bends in the proximal catheter shaft, or if the stop valve or TUI is quite tight when you are performing angioplasty. And if it still doesn't go, it means that the catheter is broken and you should replace the catheter. And in summary, there are 4 types or 3 types you can call. You can actually mix and match the types of plaques. The soft plaque, which is mainly consists of fatty acids, fibrotic plaque, which is the main dominant plaque in the coronary arteries, and then there's a calcified, and then in about 35% of the patients, the plaque is usually mixed, which is either fibrocalcific, fibrofatty, or it contains everything. So this is an example of eccentric plaque, which means that it occupies 90% of one side of the artery, and other part of the artery is generally clear apart from slight thickening of the intima. And the next picture shows the concentric plaque, which means that the plaque is against the wall of the artery throughout the whole cross-sectional segment of the artery, as you could see. And the next one is a mixed plaque, and that is a bit of calcium, bit of fatty tissue, and a bit of fibrous tissue. And this is how we do the basic IVUS measurements. When you are in the cath lab, I usually concentrate on 2 measurements so that it does not delay the procedure. You can measure the luminal area and also the diameter. And sometimes some interventional cardiologists, they do size the artery from media to media, from this black to this black area, and that can actually may sometimes be associated with complications such as sphere dissection or perforation, but it can also result in the best optimization of the stent. So now you could see that the way it has been drawn. So this is the lumen, and then automatically nowadays the machines give you maximum and minimum lumen diameter. So this is just part of our interaction slide. Can anybody guess what it is? Just one single answer, please. This is just a normal artery. You could see very clearly the intima, media, and adventitia. This is a very clear picture with the mechanical IVUS. So there's another example, and that is again the mechanical IVUS system, and that is showing that it is a small amount of fibrous plaque, and it is extending further into the circumferential part of the artery. And the next one is, so this is interesting. And any takers on this, please?
Mixed plaque.
Yeah, it starts with a mixed plaque, but as I'll put it again, and here it is a calcified plaque, which is about 80-degree arc. Now it is becoming the circumferential calcium, which is 360-degree arc of calcium. So it is a severe calcified, superficial calcified plaque. So this would require calcium modification strategies. And then One of the most important aspects of intravascular ultrasound is how do we assess the left main stem. I divide the left main stem, it is from intravascular ultrasound point of view, if three segments, when you are performing intravascular ultrasound of the left main stem, you should concentrate separately what is the distal left main stem looks like, what is the body looks like, what is the ostium looks like. This is very clearly demonstrated. This is the ostium. Ostium of any artery, whether it's a left main stem or the right coronary artery, is part of aorta as well. So that's why we call it an aorto-ostial lesion. I don't want to go into details. What are the other significance of aorto-ostial lesion? The majority of us would know about that. So this is part of the aorta and part of the opening of the left main stem. And then you will come to the body, which is showing there is significant narrowing. And then this is the distal left main stem. Anybody has a guess whether on IVUS what this distal left main stem, on measurement what this distal left main stem look like? Because on angiography, it doesn't look too significant, but on IVUS, without even measurements looking significant. So after the measurement, you could see that there's a significant plaque in the ostium, and then the body, the luminal area is 7.2, and the luminal area of the distal segment is 4.3, which is significant. So that's why if you are doing IVUS of the left main stem, you make sure that you, the physiologist or another doctor who is helping you, make sure that you do have three measurements, one at the ostium, one at the body, and one at the distal segment or the distal left main. And this is an example of a right coronary artery ostial lesion. Again, you could see there's a part of aorta and part of the artery. So sometimes you have to extrapolate the ostium, and once you have developed a considerable experience of doing IVUS a few times a week, then you can easily extrapolate the ostium. Here you could see in the longitudinal that this is the RCA ostium and this is the aorto-ostium. And this is just an example of a side branch. Here we go. The side branch comes and joins. This is again a very clear demonstration with the mechanical intravascular ultrasound system. So this is one of my favorite slides, and that shows that what is bioresolvable stents look like on intravascular ultrasound. And now we do not use it, but I had this old slide, so I thought I will just include it. These polymer struts are not as reflective bright as metal struts in case of bare metal stents or in case of drug-eluting stents. In polymer, the ultrasound waves are reflected from the front and back surface of the BRS strut, which is visible as two layers or dashes. And the ultrasound waves cannot reflect from structures parallel to the ultrasound wave. The remaining two BRS walls are not visible on the intravascular ultrasound imaging. As you could see that there are two struts on the IVUS beam. And this is a comparison of IVUS Opticross, which almost got a depth of about 6 millimeter compared to OCT, which got a depth of 1-2 millimeter. So In-Stent Restenosis, which is again a very important aspect of PCI. And we all know that despite the drug-eluting stents, we still have about 6 to 7% chances of restenosis of the coronary arteries. There are three different measurements which I have done, and this is all neo-atherosclerosis or intimal hyperplasia. Here there are two layers of the stents, and you could see that there is a small amount of intimal hyperplasia between the lumen as well as this stent border, and then again the small amount of intimal hyperplasia. In-Stent Restenosis assessment is very important. I always say that the treatment of In-Stent Restenosis starts with imaging and finishes with imaging. So if you have got a patient with In-Stent Restenosis, do not hesitate to image it, because you may be hiding some surprises. For example, underexpanded stents, unopposed stents, crushed stents, there's so many things. And usually intimal hyperplasia on IVUS appears with a very low aquagenicity, which is less than the blood. Sometimes some physicians flush during that to actually make it more visible. And this is just an example of unopposed stents. You could see that the stent is a rather very small size in a big artery. That has resulted in complete unopposition of the stent struts. And then on the right-hand side panel, still, despite the high pressure dilatation, the stent remains unopposed. And this is an example of LAD stent malapposition, where you could see in the bottom panel that the struts are not opposed to the wall of the artery. And this is immediately after stenting, and this is long-term follow-up that was after 12 months. And this is again LAD stent malapposition. You could see a clear difference between the stent struts and the wall of the artery. And you can also appreciate that on angiography. And this is what stent thrombosis looks like. On angiography, the artery is completely blocked or occluded. And from proximal to distal, you could see that there is a filling defect in the thrombus containing lesion. And similarly, you can appreciate on OCT that the OCT is considerably a lot better, picking up either acute or subacute stent thrombosis. So we all talk about stent fracture, but it is sometimes very difficult to appreciate stent fracture on angiography. If you want to look at the stent fracture via angiography, the best thing would be to do a stent boost. And you could see that on this stent boost, usually when there's a simple rule of thumb is that when there's a gap between the stent struts, that is stent fracture. Different people will just say that, oh, this is stent fracture. You have to prove it on IVUS or angiography. And here you could see that not only longitudinal, it has been demonstrated there's a gap of the stent struts, but also here we see underneath on the IVUS as well and on angiography. And then again, another example of stent fracture. And this is with the 30 megahertz catheter and follow up with the 40 megahertz catheter and focal intimal hyperplasia with paucity of stent struts is likely due to fracture. That's exactly what I was saying. On this one, you could see that you could see 1, 2, or 3 struts, but there is a paucity of struts, and therefore it is usually due to stent fracture. And now the next,
we have five more minutes now.
Next is a dissection. You could see that there is very clearly flaps, and then there's the next intramural hematoma. You could see that 2 lumens, and the next is just showing 2 false lumen. And I will skip this false aneurysm by intravascular ultrasound, and I will go up to the scenarios.
On the scenarios, we will start taking opinion from the expert panel and then go for the scenario.
Okay. So this is a 65-year-old patient. 1 year earlier, the LAD was treated with a 3 millimeter DES, This time the patient was admitted to hospital due to new symptoms, unsuccessful attempts to open a calcified lesion, the proximal circumflex with a small balloon by another cardiologist. Patient was referred for possible rotablation, and I think that should have been the question, what should be the next step? So any opinion from the expert panel, please?
Hi, great overview so far. Sorry, I was just answering one of the questions in the chat box. I've missed the scenario. Maybe you could just briefly just repeat that.
This is a 65-year-old patient, Sohail. 1 year ago, he had a DES with a 3 millimeter DES, and he was readmitted with troponin positive chest pain. And this is his angiogram. And somebody tried to go through the circumflex ostium, but failed, and therefore referred to someone else.
Yeah, I guess what we're seeing here is probably an issue with stent undersizing in this vessel. I mean, normally in a 65-year-old male, you would expect the vessel to be a lot bigger than a 3 millimeter. It's always useful to know what the size of the stent is and whether they've post-dilated. So obviously a 3 millimeter vessel, sorry, a 3 millimeter stent can be grown up to sort of 4.5 millimeters, and you can do that with post-dilatation non-compliant balloons. So the issue here, I guess, is possibly undersized stent, but there's also an issue at the left main stem bifurcation as well for this gentleman. So I would probably think about performing intracoronary imaging for this chap, work out what's going on. What did you do?
There is a significant lesion on the circumflex ostium, which has already been attempted. So elective rotablation, that was the strategy under IVUS guidance. So IVUS was performed on the LAD. After crossing with the rotawire, the plaque modification was achieved with the 1.5 millimeter burr in the circumflex ostium. And then there was smooth channel which was created. And then immediately after 1.5 burr, the rotawire was exchanged with the ordinary guide wire for further support. That's what we all do. And at the same time, obviously, after the rotablation of the circumflex, it was important to put another wire on the LAD. That's what we did. And this is the IVUS run. This is an IVUS sorry. Here we go. So this is a long run, and I can let it run, but this is the circumflex run, which was the pre-PCI, after the rotational atherectomy. A lot of calcium. I think because of the time I can, so then the next run was in the LAD. You could see that. And I think the LAD stent, according to my estimation, looked reasonably well opposed. And but there was areas of narrowing in the artery and with a bit of calcified plaques. Any opinion from the panel, please?
Farhan and Shadia.
Yeah, I think just what I suppose, I don't know what you think, Prof, but it looks like there's some atherosclerosis they're developing, but not massive inside that stent, as you said. With obviously you can see the calcium burden, more fibrocalcific there, I think. I don't know if you agree, but then there now as you're going, there is a marked decrease in the luminal area there as you're going through there, with the calcium around that area between probably 7 to 11 o'clock, really. But yeah.
Anything else? So I will go to the next one. So what I found, I don't know whether anybody picked up on in the last run, I thought left main was significant. And once I did the measurement, it came up to a 5.03. I think, Sahil, you did point out that there appears to be something in the left main, and that is significant, which is 5.03. So from circumflex, it has now become some form of intervention, not only to the circumflex, but also to the left main. So I will go immediately to the next one. So one can use any technique now. It has become a bifurcation lesion. And so, I mean, I went for one of the techniques. Whosoever you feel comfortable, one should do that rather than which one is better or which one is no better, particularly for left main. So then there was a 3.5 into 6 millimeter stent was implanted into the left main in the direction of the LAD. And because the circ, ostium and part of the distal left main has already been dealt with, 3.2 into 20 millimeter stent. And after that, we went across to the stent implantation in the left main. So you have to, I think I'm conscious of the time. And then another wire was used to cross the circumflex, and then 2.7.5 millimeter NC balloon was introduced there just to open the struts of the circumflex stent. And that was inflated at about 16 atmospheric pressure. And after that, then this NC balloon was inflated. And now you could see that then a 3.0 into 15 millimeter drug-eluting stent was placed in the proximal circumflex across the cells of the previously implanted stent. So we have made enough hole through the struts of the stent, which allowed us to put a stent through that. And then obviously my two favorite techniques are either tap or blocking balloon, or I mean, so sometimes very, very rarely I use Q-Loud. So then the tap, which stands for T-stenting and protrusion technique, and it was applied to the proximal circumflex. And then obviously you could see the stent is fully up. And after that, then kissing balloon time, 3 into 15 millimeter, 2.75 into 15 millimeter NC balloons were inflated, both in the left main and LAD bifurcation. And the next, the pot technique with a short 4 millimeter NC balloon was applied to in left main to achieve the optimal stent expansion. And the next one was, this was the final result. You could see that not only the left main stent is now fully expanded, and then there is a circumflex stent, which is fully expanded. And then on the IVUS, you could appreciate that it is very important to check your result on the IVUS. That's what I usually do. Looks like the stent is reasonably well expanded. Any comments on the IVUS from the panel?
Yeah, so I mean, obviously, when you've done the post PCI IVUS one, there are a few important things that you have to appreciate. What you want to make sure is that the stent is well opposed to the left main stem. There aren't any issues at the bifurcation. But what you also have to appreciate is that you're trying to maximize the area within the left main stem. And we know that actually, if you look at the data, so we have some data from the Excel trial, which tells us that actually, if you're going to achieve areas of around 11 millimeters squared in your left main stem, then your restenosis rate is going to be really very, very low indeed. This is slightly higher in terms of accepted area to what we see from the Korean data, which came out a few years ago. But two important things: essentially optimization in terms of the stent to the vessel wall and increased area to reduce your risk of restenosis. So that looks like a fantastic result that you've got there. What was your area out of interest, Professor Ahmed?
It was 9.6 when we did the measurement, which is pretty good actually. Anything close to about 10 is my main aim. My main goal is with these interventions.
And did you do, sorry to interrupt, but did you do IVUS into the ostium of the circumflex? The reason I say it is that I don't do a tap for bifurcations. I don't know whether it's just because I've been brought up on more contemporary technique, but I would, for this type of lesion, I would always do a culotte or a DK crush, just because I'd be so concerned about missing the ostium.
I think one thing, let's not forget that majority of people don't realize that how big the left mains are. To be honest with you, if you are not in a situation where there is either you are dealing with a very large dominant circumflex, or you are in a situation where there is a severe ostial left main stem and hot ACS, or I think you will have a lot of time. To be honest with you, that's why I mentioned whatever technique you know better, that would be the technique. To be honest with you, although the data about DK crush is the best, but even DK crush, you do not have to follow every single step. You can still modify and do the DK crush in whatever way you want, but as long as two main important thing I always stress on left main stem is that KBI inflation at the end is the single most important. Getting an optimal MSA in the left main stem, in the distal left main stem, and the body is very, very important. So I will go next to the next case. The next one is 75-year-old male, which is slightly less complex, with exertional angina occurring with less activity, and he got diabetes, hyperlipidemia, stress MPS is positive, and this is his angiogram. And what would people do? FFR or IVUS? Quick question.
Dr. Shazia Hussain. This is a question for panel or for the whole audience?
Panel, yeah, it's a question for panel.
Farhan?
Yeah, I think, I mean, to be honest, I mean, obviously it's an IVUS talk, but I think you're answering two different questions. So obviously, if you're looking at physiology, yes, pressure will be reasonable, but here it looks, it can always be deceiving in such a vessel. So personally, I would look at doing a pressure eye, but obviously here we would have IVUS, but I have no hesitation using more than one modality to answer different questions.
I think that's a very good point, actually, Farhan, you have raised, because I would classify it as one of the lesions which is called a long lesion. There's not only plaque here, there's also plaque at the origin of this diagonal branch. So I have to treat this as well, depending upon what either FFR or IVUS shows, but I would classify it as a long lesion. And so the next one is, there we go. This is in a different projection. So obviously, I opted out for IVUS, and this is the intravascular ultrasound pullback from distal to the proximal.
Sorry to interrupt you. Can you sum up in next 1 minute or two, because there is the OCT.
I know. Let me finish. These are very interesting cases. Okay. And this is, I have to wire both the lesions. And obviously, even if it's a slightly smallish diagonal, but I think it needs to be pre-treated, and then obviously a long stent across the second diagonal branch. And then this is further dilatation. So that is the distal segment looks like. Slight pinching of the diagonal, but still TIMI3 flow. And then now, would you obviously do a full stent from here to here, or will you have a gap or something like that? In fact, this case was done by one of our previous fellows, and so he convinced me that we can do IVUS, and again, then let's put a stent proximally and assess the middle segment. So that's what he did. So he deliberately left a gap between the two stents to see if we can do some form of spot stenting, not increasing the whole length of stented segment. So this is the IVUS, which obviously did show, in fact, even on the first IVUS, quite a significant plaque in the mid segment. And the stent, both distally and proximally, is very well expanded. So this is a soft plaque in the mid LAD. That's what with the area of 3.67. And then it's a fibrous plaque. At some point, it is 3.22. And then length between the two lesions is about 33 or 39 millimeter. We often measure the length as well, which is quite helpful to guide the length of the stent. And then mid LAD stent opposition was fine with the cross-sectional area of 7.31. And then distal reference in the artery was 8.12. And then obviously then a 38 millimeter stent was placed between the proximal and distal stents with the overlap. And then final IVUS in the LAD. It's just a sort of question of showing that you got to consider before taking complex cases, you know, is it a bifurcation? Obviously, that would be obvious from the angiogram. Is it a long lesion? Is it a left main stem? Is it a calcified lesion? And I mean, has it got any other sort of things which can make it a more complicated procedure, for example, In-Stent Restenosis or vein grafts and all these sort of things, you know. So I think, and using intravascular ultrasound in such cases is extremely, extremely helpful. I mean, you can use either IVUS or OCT because both got advantages and disadvantages, you know, and but imaging is important. That is the message here.
Thank you very much, Professor Ahmed.
No problem. Thank you.
Yeah. And now we can invite Dr. Javed Iqbal for OCT talk. Thank you very much, sir.
Thank you.
Yeah. We can stop the sharing now. You can stop the sharing now.
I have.
Thank you. It's a great talk.
Thank you.
Javed, Dr. Shadia Hussain and Dr. Suhail and Farhan is around now. If you want any opinion, be more interactive.
Okay, can you hear me?
Yes, we can.
And can you see my presentation as well?
Yes, we can.
Okay. Good. Thank you very much once again for arranging this talk. I think that's very helpful. And Professor Ahmed has done a nice job of setting up the scene and the anatomy and why we use intravascular imaging. So that makes my job a bit easier. And what I've been told is there is a spectrum of attendees from junior trainees to very accomplished interventionists. So it's always difficult to pitch at the right level when it's a full spectrum of the audience. But we'll try to mix and match to give hopefully something to everyone. Okay, I was told that it will be about 60 minutes, but we can reduce it as much as we want and we can continue all night. So just a few things that we would like to cover in this talk. and obviously how to interpret and cases we can reduce if needed. And I thought we should have some interaction, so might ask the audience and the attendees a few questions, some quiz at the end. Okay, so I think Professor Ahmed has covered it, that why we need intravascular imaging, and that's true for both IVUS and OCT. And the main reason for that is the limitation of angiogram. Angiogram is your two-dimensional picture. It does not give you all the information that you need. It does not have the resolution. I think that's the main thing. It does not have resolution to answer all the questions that you may have, both in terms of diagnostic reasons and in certain cases to perform an angioplasty. IVUS, yes, it's a great tool. Still use it often, and its resolution is better than angiogram. But OCT is definitely, when it comes to resolution, that's the highest resolution intravascular imaging that we have, and that's why I think the main use of it. That's, I think, to say that what it is. So just as you have seen on IVUS, 3 layered structure of the vessel wall, that's what it looks like, the normal artery on OCT, and you can see it very clearly, the 3 layers of the vessel wall. And in the normal vessel, you will be able to differentiate all 3, and that's what the normal vessel will look like, with media and then intima and adventitia. So obviously if we have that we can do intracoronary imaging with IVUS or OCT, there are advantages and disadvantages of both. And the clear advantage of OCT is the higher resolution. HD IVUS is there, but OCT and the future of micro OCT, that resolution, I don't think it can be achieved with even HD IVUS. So I think resolution is a main advantage of OCT. Also, in terms of the tissue characterization, I think with resolution that comes naturally, that with IVUS, you will still have to struggle a bit what it is that you are seeing, what kind of tissue you are seeing. You can make a good guess. You can use, in old times, used to use visual histology as well. But the tissue characterization is much better with OCT, and we will see a few cases of the OCT where you can exactly see what you are seeing. I think still, I believe OCT is easier to do and easier to interpret. It may be difficult to decide what to do on the basis of that information because you get loads of information, but in terms of performing the images and understanding what you are seeing, it's much easier. And also with IVUS, you can get it, but the OCT, I think softwares have developed very, very quickly, and you can get a lot of automatic analysis, Lumen profile, stent deployment, stent malapposition, all comes built in these days. Obviously, there is a price to pay, not just the financial price, but otherwise it involves contrast to do the OCT. So some patients may not, it may not be suitable for some patients. If a lesion is relatively tight and you think that the OCT will block the artery and you will not be able to get a good flush of the blood, then you might not be able to do a pre-dilatation OCT, and you might have to do the pre-dilatation and then to perform OCT. Also, with higher resolution comes the limited penetration. So your field of vision may not be, the depth of vision may not be as good as you will see with the IVUS. And also IVUS we have been using for a long time. We have the data to show even the outcome data available for IVUS now, but OCT, we are getting the data, but it's not there yet. I'm not going to bore you with all these studies. I think we are all clinicians, but there are a few studies going on. And I think the one that I'm really looking forward to is the Lumen 4 RCT, which is recruiting currently. And hopefully, if coronavirus is not delaying it, then we're likely to see the outcomes of OCT guided PCI in next year or so. Okay, so when to use OCT? Obviously, that we said it's a resolution, that's the thing. I usually say that there are the reasons that you need to do intracoronary imaging, and especially OCT. It depends on whether you can have the reasons even at angiogram or after you have an angioplasty. But the main one before angioplasty is diagnostic uncertainty. You're not sure what you are seeing. If the angiogram is a hazy area, some unclear that what you are seeing, then you can get a certain tissue diagnosis and the plaque diagnosis that what it is. Lumen size, vessel size, you can measure it. IVUS can do it. OCT can do it. Plaque morphology, as I said, that's OCT is probably the best tool that we have, and it can help to plan your PCI. That what strategy you might need, whether you need where to land the stent to avoid landing stent in an unstable kind of a plaque, and how long the stent should be, what should be the diameter. All these things you can plan upfront, or whether bifurcation needs two-stent strategy upfront. Once you have done PCI, still, I think the main reason for me would be if there is an ambiguous area, there you are seeing something at the end of the stent, in the stent, you are not sure what it is. OCT will give you a clear idea what you are dealing with. You can see the stent opposition, you can see the stent expansion, and at a follow-up, if you're doing it, you can see the strut coverage. I mean, you can't see the struts covered with any other intravascular modality, but OCT can give you whether the struts are covered. You can see restenosis. And also for, I think, in cases of the stent failure, you can do IVUS, but I think OCT will give you much better understanding of the mechanism of the stent failure. So it will be my imaging modality of choice. You can see neoatherosclerosis and obviously PCI research. So when you're doing OCT guided PCI, that's kind of the MLD max approach that that has been advocated. That before you do the PCI, you want to see the plaque morphology. You can see the lesion length. You can try to measure the diameter of the vessel or the diameter of the stent that you're going to use. And once you have done the PCI, you want to see that there is no edge dissection. You want to see that the stent is well opposed and well expanded. So that these are the main things when you are using the OCT guided PCI. And I will not go through the details. You can check the element 3 criteria of the what we would say a good PCI outcome. Okay, ESC guidelines. Yes, there is a mention of both IVUS and OCT. You can use it for stent failure, and you can use to optimize stent implantation. Data are coming, and hopefully, as said, with Lumen 4, the indications, the level of recommendation may be upgraded. So that's my simplified version of when do I use OCT? I use OCT for all the cases except when I can't use the OCT. And the two main reasons for when I can't use the OCT is a large field of vision, and if I can't have a bloodless field of vision, because we said that for OCT, we need to have a bloodless field of vision. So for large field of vision, it's usually if it's a large left main stem. The depth of vision with the OCT these days is up to even 10. So I think it's not for all left main stem. We have published the data of the OCT from our center with left main stems, and you can do it in most of the left main stem. But if it's a large left main stem or even an ectatic artery or ectatic segment of RCA, you might not be able to see it or to clear blood from it. The second thing, when you cannot or you don't want to achieve a bloodless field of vision, if it's an ostial lesion, you will not be able to clear it. There are some techniques that you can use. You can even use a guideliner, and you might be able to get some image through the guideliner. But I would say it's no need to be hardliner, and you can use IVUS in that situation. If you have dissection or SCAD, and if you have wired it, probably you should not have wired it. But if you have wired it, then I would still want to avoid a forceful contrast injection and probably will go for IVUS. Or if the patient has renal impairment, then you probably don't want to do a repeated injection of contrast. Having said that, you might find that one OCT run give you all the information that you need, and you can avoid taking 3 angiographic runs. So, but that's the main reason that I would use IVUS. Otherwise, I will use OCT. If you want to look at this, this is an interesting paper from a Dutch group where they have like the American stent appropriateness criteria. They have published the OCT appropriateness criteria. I think that's interesting. I will not go into the details of this. Okay, so I think obviously we want to see how to interpret OCT. And again, I would just like to go into a very simple mechanism or a scheme of interpreting OCT. The terminology is simple. We are going to look at a few things, and then on the basis of that, we can decide if we are seeing a structure, then what it is. So signal strength Something can be signal rich, and that will appear as bright, or signal poor, that will appear as dark. Okay, so a lesion can be bright or a dark. The other thing is how homogeneous is signal. So something can be smooth, homogeneous, or something can be heterogeneous. Third thing which we want to look at, if some structure is obstructing the passage of light, meaning high attenuation, you can't see beyond that, or it's a low attenuation, meaning that it's not obstructing the passage of light and you are able to see the structures beyond that lesion, beyond that your mark of interest. So it could be high attenuation, meaning you can't see beyond it, or it's a low attenuation, you can see beyond it. And also the final thing is whatever your lesion of interest is, or area of interest is, has it got a sharp, distinct border or a diffuse border? So these are the four main characteristics that are defining criteria that we use on OCT, and based on that, we can define what structure, what plaque kind we are looking at. Okay, so if you keep that in mind, I will move to the next one of the OCT characterization of the tissues. So fibrous tissue, we have already seen on IVUS that it's usually homogeneous and it's usually bright. It's a signal rich, it's a bright homogeneous structure. It does not obstruct the light passing through it. So it's a low attenuation, you can see beyond the fibrous structure, and usually the edges are clear. So if you see a bright homogeneous layer and you can see beyond that layer, that's usually a fibrous plaque. Okay. If I will move to the third one, lipid one, on the other hand, it's a signal poor. Okay, it appears as it does not appear as bright. It will appear as dark area. Again, it is homogeneous because usually, although it can be mixed plaque, but usually the pools of lipid, it will appear as homogeneous. But the contrasting feature again with the fibrous plaque is that it will attenuate the light. You will not be able to see beyond it. So the vessel outside you will lose that if the plaque is lipid rich. Okay, so these are the two main differentiating points between the fibrous plaque and the lipid plaque. Fibrous plaque, homogeneous, bright, and you can see beyond it. Lipid rich plaque is dark, it's still homogeneous, but you can't see beyond it. Okay, then the other two structures that we usually want to differentiate are the calcium and thrombus. Okay, I think OCT is the best imaging modality for these two as well. Calcium, you can not just measure the calcium presence, but you can also measure the depth of the calcium. The IVUS cannot see beyond the calcium, so usually you cannot see how deep is the calcium, but here you can measure almost the area of the calcium. How does the calcium looks like? It's the main characteristic of the calcium is that it's distinctive sharp edges. Okay. And otherwise, the signal strength and attenuation, signal strength is usually medium, it's mixed, but it has got very sharp, distinct edges. Once you have seen the calcium on OCT, you will never forget what does it look like, which we'll show in a minute. Okay. And again, because the calcium is low attenuation, it does not obstruct the passage of light. That's why you can measure the depth of the calcium. You can see even beyond the calcium that what the vessel looks like. Then we come to thrombus. Thrombus, on the other hand, it depends whether it's a red thrombus or a white thrombus, and we will see the examples of those. But usually these will appear as a pedunculated areas protruding into the vessel wall. And if it's a red thrombus, then it's usually high attenuating, meaning if there is a red thrombus in the lumen, you will not be able to see the vessel beyond it. But if it's a white thrombus, you might be able to see through it and the vessel beyond it. So these are the important differentiating features. On the basis of these four characteristics, we can almost define what kind of plaque, what kind of lesion we are looking at. Okay, so we'll just go through a few examples of these. And here you can see the OCT pictures and the histology comparison to it. So the first one, you can see that the plaque here is bright. It's relatively homogeneous, although as I said that there is nothing like a pure fibrous plaque. This is predominantly fibrous plaque, but there are fibrofatty areas in it, and you are able to see to some extent vessel beyond it. On the other hand, in this panel B, you can see that area is appearing as dark. The light is not passing through it, meaning that it's likely to be a lipid pool. You cannot see a distinct border, so it's unlikely to be calcium. It's more likely to be a lipid pool. So it's a fatty plaque. In C, you can see that what we were seeing is a very well demarcated area, and that's the hallmark of a calcified area on OCT. And in D, you can see there is a protruding area in the vessel, which is it is more likely to be thrombus. And what you are saying is that there is a dropout. You cannot see the vessel wall beyond it. Okay, so this is going to be a red thrombus, because red thrombus is obstructing the passage of light, high attenuation. You can't see the areas beyond it. And we will see the example of the other kind of thrombus, white thrombus, where you might be able to see vessel beyond it. So again, I will not go through it, but Professor Ahmed has covered fibrous plaque and fibrocalcific plaque. But here in the second one, you can see very clearly distinct calcific areas with the sharp borders. So that's, I think, something very easy to differentiate on OCT. Again, because of the resolution, you can not only just see what kind of plaque it is, you can even measure the gap thickness. And there are some automated softwares not available in commercial setting yet, but there are in research settings, and I'm sure they will be available in due course for use in clinical practice as well, which automatically measure even the plaque gap thickness. So the top one is the fibrous plaque. It's a homogeneous, bright layer of plaque, and there is a thick cap, so it's a stable thick cap fibroatheroma. On the other hand, the bottom one, and you can see that it's the dropout beyond it, so there is the fatty plaque, and you can measure the areas of the thickness of this fiber cap here, and it's a thin cap fibroatheroma. So that's the thing that we are saying, that you can appreciate what kind of plaque it is. It's a stable plaque on this side, and as we were saying, repeating, I think part of it is that you have to see these things repeatedly, and it's a pattern recognition. Those 4 points that I've told you, that on the basis of that you differentiate these things, and that's how we differentiate. Okay, so I am now going to ask one of my colleagues in the panel just to just say one word about both of these pictures.
I don't mind talking. What I can see on the picture on the right is what looks like a white thrombus there, possibly an area of calcification. But when there's white thrombus, it makes me think of whether or not there's a plaque erosion with white thrombus on there. Yeah. So otherwise, fairly circumferential fibrous plaque.
Absolutely. So that's absolutely agree. I think that's what it is. And as we said, that there is a protruding irregular kind of mass. That's a small thrombus there, but you can see the vessel beyond it. It is not causing so much of a light attenuation. So it's probably roughly freshly formed platelet-rich plaque, platelet-rich thrombus, and with a ruptured plaque or eroded plaque. Okay, we have talked about calcium. Here you can see almost 360-degree calcium in this artery, and it's a thick layer of calcium, but you can measure how deep it is and what's the depth of it, what's the whether it's 360 or whether it's just localized calcium. On the other hand, in the other one, Sohail, that's your favorite one?
Sorry, which, the one on the right?
Yeah, the bottom one.
Yeah, so the one on the right, what we're looking at is probably a calcified nodule there. It's protruding within the lumen of the vessel. And I guess on the beauty of OCT is you can measure the thickness, as you've said, which you wouldn't be able to do on IVUS.
Yeah, absolutely right. So I think that's the advantage. And if I'm planning for doing an imaging guided PCI for calcific thing, I think OCT gives me a lot more information. And here, as you said, you can see a 360-degree calcium or a calcified nodule. You can plan your strategy, what you want to do.
Javid, do you mind if I just interrupt and ask you a question there on that last
Sure.
slide? Is that okay? So I tend to reach out for IVUS more than OCT, and to be honest, and one of the reasons is vessel sizing, which is one of the disadvantages. If we go to that, I would find it difficult to determine where the external elastic lamina is and to size on that. I know we're supposed to take reference vessels either side, but just based on those images, where would you size from and to?
Absolutely agree. There are advantages, disadvantages. The sizing on OCT, you have to be much more careful. I'm sure you know the criteria used in Lumen 3, which is EEL-based criteria. But yes, for some of our patients where you never find a normal vessel, it becomes a problem. And then you have to use, I would be honest, then you have to use the clinical judgment to some extent and upsize your stent size based on the best area that you can see, because you're right that in some areas you will never be able to see an EEL. Okay, that's another one that Shazia has just said. That's probably one of those. This patient comes in with an ACS. It was normal looking angiogram, some concern, and we did the OCT, and I think it's a plaque erosion with a bit of a white thrombus attached to it. And that was another one where we were happy with the outcome of our PCI. Stent looked nice on angiogram, and we were about to finish, but just because we have already had the OCT opened before stenting, so we just thought, okay, let's do the OCT, and that's what it looked like, and we had to post-dilate it. Okay, we'll just play it, and maybe one of the panel members just say something about it. So this is a patient who had PCI a few years ago.
So it looks like quite homogeneous there within there. So obviously there's an element of atherosclerosis there within the pre-existing vessel. Quite a lot.
There are also two stents.
Looks
like two stent
two
layers.
layers, yeah.
Absolutely, he has two stents, and also, although it looks homogeneous, but there are areas which look like neoatherosclerosis as well. There are some vessels formed, and I think that's homogeneous, but with some areas of neoatherosclerosis in it. That's another one. This patient had PCI 5 years ago, and that's a treated segment. Any comments?
I'm struggling to see the stents here, so I'm just wondering whether he had a bioabsorbable scaffold put in.
That's right. That's yes. That's one of those which had good outcome, I think. Yes. And the first picture on the you actually can see the marker, but otherwise there is no stent, no scaffold after 5 years. Okay, we have talked about thrombus. Okay, so I would like another member to just comment on the basis of what we have already talked about, the thrombus and the two types of the thrombus.
You can see the difference between the high attenuation and the low attenuation. So the high attenuation is on the right, which is red thrombus, more likely to be associated with plaque rupture, whereas the white thrombus is low attenuation, usually more well-defined and more likely to be associated with plaque erosion.
That's right. I mean, here you can see both of them look similar, but here you can see the full thrombus. In the red thrombus, you can't even see the full thrombus because the light is not able to pass through it, and definitely there is a big hole in the vessel wall because you can't see it beyond that thrombus. So this is an area of red thrombus. This is an area of white thrombus, and as Shazia pointed out, and knowing some of these things, that why it is what it is, then helps you to understand the mechanism of ACS presentation.
The other important thing on the picture on the right actually is that you can see that there's probably a lipid-rich plaque there around, between 3 and 5 o'clock. I don't know if you want to just point that out. And then you've got this sharp demarcation and quite high, rich signal, which sometimes can tell you about the presence of macrophages, which of course are involved in plaque rupture and also erosion.
Yeah, that's right. Okay, and that's anyone want to comment on this one?
That looks like an OCT that I've done.
I'm glad just
so
I'm
I think
glad you say that, Sahil, because I have this problem with OCT, and it's no matter how well prepared you are, how well your guide is, and you will get this. And this is the only thing that makes me take out an IVUS catheter rather than OCT. If I could say without doubt that I'll get reproducible results that are good every time, then I would. So I don't know whether it's just me or it is a universal problem.
Yeah, no, I think, and it also depends whether you're doing hand injections or injections via the pump. And I have to say, most of us certainly I tend to do hand injections rather than bring the pump out for these. You will get better clearance if you do pump injections. And if I failed on hand injections after 2 runs, then I will call for the pump. But you're right, I think very proximal vessels, it can be a bit of a struggle, can't it, Charles? So.
Apart from the proximal vessel, I doubt that you should see it ever. And that the main point of bringing it is that it's important that, I think that's what Shadia said, that's very good that she said, but honestly, this is something that can be easily avoided. We need to make sure that the catheter is well engaged. And once your catheter was well engaged, you have just put your OCT catheter down there, and you might see that your catheter is not as much engaged, and you have just tried to acquire the image without checking it. So as a matter of routine, I will always check before starting to inject that yes, my catheter is well engaged. In some cases, use of the card liner may also help, but it's very occasional. I think but Sohail pointed out that use of the injector is, yes, that's helpful. I always find that I trust my hands more than injector, and I don't have any problem, but I always use a 20 ml syringe. And for the OCT, there are now dedicated 20 ml syringes available. You can I think flush it better with those 20 ml syringes rather than your normal 10 ml syringe that comes with the angioplasty pack. And also, I mean, different people prefer automatic or manual pullback, but you have to make sure that you are using the right settings. So those are the things that I think must be optimized. And Shadia, the same thing I have heard from some of the colleagues who have more experience of OCT, the younger ones, and less with the IVUS, that they struggle to get the good IVUS images. But I think both of these things can be improved in terms of the IVUS acquisition or OCT acquisition.
You also need to make sure you've had a good breakfast in the morning or a good lunch.
Make sure I have my Weetabix.
Yeah, I'm not going to go through all the artifacts that we can see, but this is a very good paper in JACC, which I quite like it, and it describes different artifacts. NURD, Professor Ahmed has mentioned already. NURD you can see in OCT as well, and the artifacts I said that this is very good paper if you want to read through it. Okay, so we'll just quickly go through some of the cases. We don't have to go through all the cases, but we'll see how much we can cover. Okay, so 37-year-old man, he was on a treadmill, gets chest pain, he collapses with the VF, admitted at his local hospital, who did the angiogram and referred him for ICD. I think we have got the angiogram pictures. Okay. You can ask for 3-4 more angles, but honestly these were the best ones. So Okay, I'm not sure whether Emma, you can run this poll. We thought we just ask the audience as well that what would you do? So the patient had the angiogram, had BFRS, referred to you for an ICD. Emma, is it possible to run the poll?
I'm trying it.
Is,
Yeah.
or okay, fine. So here's the poll. You can answer this one. And I think there was some this IT glitch that you have to put just option 1 or option 2 at the end just to submit it. Can I ask all the audience that see what they would like to do with this case?
Yeah, it's working.
So just select the answer from 1 and just put option 1 or 2 at the end and then submit it. If it allows you to submit. Yes, it has allowed me to submit it.
Yeah.
What answers did we get, Ahmed?
I can now end the poll. Something else, 63%.
Okay, something else. Okay,
Yeah.
fine. So I will ask our expert opinion then. What is something else?
Well, since we're on an intracoronary imaging course, I would hope that you would reach either for the IVUS or the OCT catheter. I mean, the thing is, when you're asking the question about imaging, it really depends on the answer that you want.
It depends on what you are
And
thinking.
the technique
That
you select
what you want.
depends on the question that you're answering.
Yeah. Okay. Am I back online? Yeah. So
I think you have to define the question first, don't you? And I think in this scenario, what you're wanting to make sure is that there isn't any evidence of plaque erosion. Possibly, this could have been a Minoka episode. There could be SCAD. So those things are probably better imaged with OCT rather than IVUS. So that's probably what I would reach for in this scenario.
Okay, here you go. That's the OCT picture of the same artery. And I would ask one of the panel members to just keep commenting on it while it's running. So I think what we are seeing here is that there is a small area of proximal LAD where there is a significant lesion. I think because of the tortuosity or whatever the angles, it was not that much appreciated on the angiogram, but this is the area where the lumen looks quite tight. And otherwise, the rest of his arteries were not actually too bad. And there is plaque, but the left main is good size. And the distal vessel is also good, but there is a small area of lesion. I don't see an obvious thrombus here, but obviously it depends also that what's the time scale between the presentation and this picture. Okay, I think we've done that. That what did it show? So what we did, rather than ICD, we just stented his proximal LAD, and he has done well with no further problems. And I think that his presentation that he was on gym, and then he developed chest pain and BFRS fits more with the ischemic, and his LV function was fine. Okay, that's another one. This guy is 29. He had chest pain, cardiac arrest, ST elevation on ECG, pain and ST elevation resolved on arrival to the cath lab. I might ask the panel members, if it's the middle of night, would you take him to the cath lab, or would you say in the morning?
No, I'd take them to the cath lab. We don't know what the underlying pathology is, and if they've got ST elevation MI. I don't think there's anybody who wouldn't take them to the lab.
Yeah, I agree. He's had a catastrophic event, hasn't he? Which is a cardiac arrest. So you really want to know what's going on.
Okay, so that's right was fine, and all the arteries were open, patent, flowing.
What territory was the ST elevation?
Anterior. So that's my next question. I don't know whether we can run it, but
It's a,
And obviously, what you would do depends on what you think is in your mind.
the poll number 3 questions. Yeah.
Yeah.
I can match it now. I think so this year we all biased with OCT.
Yes, it's an OCT presentation. I actually had to cut a few cases from in between because there were some cases where the answer was not OCT, and but unfortunately, due to time, I had to cut those cases. So, yeah, let's see what the answer is.
Yeah, 55% share result. I'm sharing the result.
Yeah, I think some of these things are not mutually exclusive. If you have done an intracoronary imaging because your coronary catheters are all already there, and it does not stop you from doing an LV angiogram, and that would, depending on what you think, and afterward that does not stop you if you are thinking that it's an aortic problem or a myocardial problem. So I think I agree that I will go for a form of intracoronary imaging. Any comment from panel?
Yeah, I mean, just looking at this angiogram, the angiogram doesn't look particularly healthy for a 25-year-old, does it? It looks like he's got abnormalities with atherosclerosis, certainly within his LAD.
That's right. And for that reason, I think when we are saying intracoronary imaging, I would definitely go for OCT in his case, because we want to see if there is what's the plaque morphology like. Okay, so yeah, OCT, run that. So that's a quite normal looking mid LAD, and we are coming proximally and into the left main, and that's what you see. Shadia, that's your favorite one?
I didn't want to go on about plaque erosion again with white thrombus, but I think that's obvious for everyone to see in the left main.
Yeah,
bit unusual.
I think it gives us the diagnostic information that what happened to this gentleman, and then you have to make the decision of how you want to treat it. So it showed the evidence of eroded or ruptured plaque. Depending on what time it is, I've just we had a short, I think 10-12 minutes recorded of how to do an OCT. I was not sure that whether that, depending on, I mean, what's the level of attendees, whether that will be of any help or whether we should just skip it.
I think so we can skip it and probably can go 1 or 2 more scenarios other than this.
So, but just out of interest, what did you do with the young chap with the plaque erosion?
I have now, I would say, probably about a dozen cases. I need to write up those where there was a ruptured or eroded plaque with the non-flow limiting lesion, and I have treated all of them medically, and they have done very well. So I don't think at the moment there is any data, any evidence to suggest that ruptured but non-flow limiting plaque need to be sealed with a stent. That's my personal opinion about it. Again, there is no data for supporting or refuting it at the moment. There were some studies, I think secret trial where I think a 65 micron stent was used for plaque passivation, and a couple of other small studies, but no proper randomized trials. But my personal feeling is that these non-flow limiting but ruptured plaque, it's the medical therapy.
Do they ever represent again? I mean, my concern would be if they're treatment naive and that happens, and they're not on dual antiplatelets, fine, you've escalated their treatment to prevent a recurrence. The issue would be is if you had a recurrence on dual antiplatelet therapy, then I would be concerned. And to be honest, I'm not sure what the right answer is.
Yeah, I think you have to individualize these things. You can never say, yes, that may be one consideration when the patient is treatment naive. And to be honest, those ones that I've mentioned, those were youngish patient treatment naive, and they come with plaque rupture, treated medically and did well. But if somebody has got moderate atheroma, which you will probably see with those ones who are elderly and on the treatment, they will not have otherwise normalish looking vessel. This guy, you have seen that the rest of the vessel was very normal looking, and that's why I treated him medically. But the other ones where there is moderate plaque burden and plaque rupture, you might want to stent it. I don't think there is anything against it. I think we need more evidence for that. So, you wanted to say something?
Yeah, I was just going to say, I mean, that's not a bad strategy to adopt. And I have to say that's what I tend to do if there's no flow limiting lesion within the vessel. There is the erosion study, which has looked at patients like the one that you've described. And of course, it's not a randomized controlled trial, but it's just a prospective observational study, which seems to suggest that this is not a bad strategy for patients. And of course, high dose statins is the other thing to help stabilize the plaque. Yeah.
And the ones that, Shadia, you are mentioning that you are concerned that they might have another event, depending on what their scenario is, a small proportion might have a stent thrombosis event as well. So I think we have to balance that. Okay, fine. I think, okay, fine. I will just miss that one, but this was just...
There is a question, it's an interesting question, I just on the chat box. Question, if you put a wire in the totally occluded LAD and clot get removed and there is a mild non-flow limiting plaque underneath, should we stent it or not?
I don't. Again, if it's a normalish looking vessel, I don't stent it, because the stent for me is the treatment for a stenotic lesion, not for an eroded lesion. And again, very small number. I have even 2 or 3 patients who, for some reason, it was such a heavy thrombus burden that I had to, we're talking about now controversial topics, but that I had to give intracoronary TPA, which resolved their thrombus completely. I gave them a regime of antiplatelet, anticoagulant, brought them back a few days later, did the OCT, vessel looked fine, didn't stent it, just treated medically. But these ones have to be carefully individualized rather than just saying that we will do one thing or the other. And usually, I mean, you will have, for example, if you didn't stent it at that time, you got good flow. I think main thing is to achieve good flow. That is the main thing to achieve in all of these cases. Even if you put a stent and your flow was suboptimal, that's my view for the thrombosis. If you have achieved good flow, then the body's own TPA, that works absolutely fine. So the main thing for a vessel is to achieve a good flow. So whether it's a STEMI and you have stented, or whether it's a STEMI you have just did some export catheter thrombus aspiration, or whether you think it was just a small plaque eroded and you didn't need to do anything. If there is a good flow and then you have given the appropriate antiplatelet, anticoagulant therapy, patients will be fine.
Farhan has an argument against it. Farhan, can you? Farhan is there? Farhan is saying, I would stent an occluded vessel without hesitation. This is what happens in STEMI often.
Yeah, that's what I would do. Yeah, I'd very much do. I think what Iqbal is saying is right. Obviously, it's case-based, but in the common practice, say there's a 75-year-old, everything fits with the STEMI, I'd probably be a lot more comfortable in that scenario. Yeah. When common things are common.
The ones that we are saying is that, yes, how many of these cases where a patient come with a STEMI and we don't stent it, maybe 2 or 3 cases a year. So you are absolutely right. It's 99% of the cases, it's the wire balloon stent. But it's one of those where, for example, this is just a plaque erosion and there's no stenosis, no residual disease there. These are the ones that you may want to leave it alone. And many times when we are not doing the imaging anyway, we wire it and we see some flow achieved. Some people will just go for a stent. I might use a very small balloon just to achieve some flow and then put the stent there. So you're right, Farhan, that for almost 99% of the cases or 99.9% of the cases, that would be the strategy. But in a very selective cases, yes, if you have managed to achieve a good flow, there is no residual stenosis, and there is only a bit of plaque erosion and plaque rupture, and you want to leave it, I think that's reasonable as well. Okay, I think so. Fine. If anybody wanted, I can send it. But this is more. The video was more of how to set up the OCT, because I think it's easier to show it rather than talking about it, and also the software that the OCT systems use, and both in terms of the stent malapposition and things.
Wait, we will share this whole session later on the YouTube, and probably
Yeah.
people can watch there.
That's
Shadi Hussain is more
so
worried about the
again,
Zoom fatigue.
yeah, I think in that case we probably should, as I said, that there is this is another
We can
case.
go for next one scenario, probably one more scenario.
Okay, let's just do this one then.
Yeah, okay.
I think that will be interesting. So panel ready?
You're putting us on the spot, are you?
Yes, of course.
They can't escape now.
So yes, so we'll show you 5 images only. It's a penalty shootout, 5 you get each. And what I would probably say, just to make it interesting, the problem with these ones is online is that no attendee, I can't see anyone. I don't see how they can interact. The polls work to some extent, but I'm going to ask Ahmed, who is coordinating, to just randomly select one expert panel and one attendee, and they have to answer it. Okay. But I can assure all attendees that it's heavily biased, so you should be fine.
I will just one before. Dr. Kumail Gishkori, you are ready?
Okay. So, and which one from the expert panel?
I will go for Farhan.
Okay, Farhan, ready? So you just have to say stable or unstable lesion. Yes. So for the first panel that we are going to show, that is for Farhan.
Yep.
Farhan, stable or unstable lesion?
Unstable.
Okay. And that's one penalty. We will see the answer in a moment. But sorry, who is from the attendees we are going to?
It's Colonel Kumail Gishkori. He is working in QE.
Kumail, can you unmute yourself? Are you ready?
Yep. Yep.
Okay. Stable or unstable lesion?
It looks unstable. Sorry, stable.
Okay.
Sorry, stable.
Okay, that's fine. That's fine. So he got exactly what England did the other day. Missed the penalty, but on the rebound he goaled it. So that's fine.
It's
so,
stable. No area. No.
It is stable. You can see that it's a homogeneous layer, bright homogeneous layer, and you don't see any disruption. You don't see any clot. You don't even see a tikva. So this is the same patient. Farhan, the point is not to say that the expert person cannot say it. It's just that the angiogram cannot tell you the story, but that's what it is. It's the same patient, and it's a stable plaque.
I must admit, if I saw that in an ACS,
I was not going to give you any history. I was not going to give you any other view, but that's because the OCT was also for just one image, one view. Okay, fine. So it's 0-1. Ahmed, who's next?
Shazia Hussain. Shazia is there?
Yeah, I'm still here.
And from there, I will go for Azim Sheikh. Azim is there?
Can you unmute yourself?
If Azim is not there, then Ali Raza. Yasir Pervez is there. Yasir is your friend. He is the right person.
Yasir is an expert. You should attend. You should select a training.
Oh, then
I'm sorry to disturb, man. It's time to sleep in Dubai.
Yasir, it's amazing you are here, sacrificing your private practice.
I'm happy with the Yasir.
I spent 2 years, man, learning from you. That's why. To carry on.
I think so. Yasir is fine. Yasir
okay.
Yeah.
Fine. Let's stay. Same question. Shazia.
Gary Mint says you cannot.
No. Yasir, you wait. It's for Shazia.
I'd like to say that I want a clinical history, but based on that appearance alone, I'd probably verge on that it's a stable lesion.
and the OCT of this guy.
Of course.
Yasser, there is no goalkeeper. You just have to score.
Yeah, unstable now because we have seen that there is some thrombus and something is happening there. Yeah,
Okay.
unstable.
So I think I'm proving my point, right?
And another thing, you gave the same talk in Pakistan Cardiac Society, and I was there in the audience.
Oh, that's cheating, Yasser. Okay, who is going to do this one?
Now there is only Suhail left, and I can select from one trainee.
So we got just 3 more, and then we finish.
Maybe Asim Chugtai. I'm not sure they are intervention trainees or not.
That's fine. I think the beauty of OCT is that you don't need to be interventionist.
Any volunteer?
Yes, I'm now.
Okay. Yeah, he's there.
Okay, Sohail.
It looks like probably a calcified lesion where you've circled. I mean, the whole vessel looks calcified. So I will go with calcific. But of course, you can have both together. You can have calcific and fibrous, and it could also be thrombotic. But based on the angiogram, I would go with a calcific lesion.
Okay.
And now Asim, your turn.
Yes, looks stable lesion. Calcified but stable. No ruptured plaque or anything.
Well done, Sohail. Yes, there are some markers. You can see even the proximal part of that RCA. You can see that either there is a stent or there is a calcified lesion. But you are right that you always you have to take it with the history. Was it a stable presentation, unstable presentation? It could be mixed. But with the OCT, I think that makes interventionists even less likely to ask history. Okay, so second last. Ahmed, for you yourself.
Okay, go ahead.
And who is going to be the trainee?
Zishan Hassan, are you there?
Yes, I'm here.
Okay, good.
I'm here.
Okay.
Okay. It looks to be calcified artery.
Okay, Nishad. You want to change your answer, Ahmed?
Yeah, it's a thrombotic.
Thrombotic, yeah.
There is a thrombus, and it looks like a white thrombus.
Excellent, excellent. I mean, these are all, I mean, they are much better interventionists than me, honestly speaking. They are senior and I have a lot of respect for them. The aim of this one was not to say that they can't tell what it is. It's on the basis of angiogram without history, with just one view. It's almost impossible. I would definitely have scored 0 on this one. So you are not, the point is just that with the angiogram, there is not enough information, enough resolution, enough depth to make some of these conclusions. Okay. So Professor Ahmed is not there, but you know. I will just that. Yes, so that one is, can anyone want to comment on it? But the IVUS, yes, when I'm looking after this OCT, I can make it, oh yes, there is something going on there, but I would have struggled. Is it this, is it something else?
It is dissection.
Yeah. That's why I'm saying, Professor, you would be able to see it easily on IVUS as well. For me, the OCT is just making it easier. Okay, I think I would stop here. Any comments, any suggestions from the panel, from anything in the chat that we need to discuss?
Can I just say it's been a fantastic overview by both you and also Professor Ahmed. So thanks for taking time out to do this. I mean, maybe I can just be a bit provocative. So, you know, there are about 100,000 angioplasties that are done in the UK a year. And out of that, about 10,000 have IVUS performed. something like 3,000 have OCT. What do you think are the main barriers to stop individuals using intracoronary imaging more often? Is it the fact that they don't have time in the cath lab? Is it the training? Is it the interpretation of the images? What do you think is stopping and holding people back?
I mean, I can answer that question. One of the most important thing is there was an article in the American College of Cardiology that now there have been about 5 meta-analyses and 3 randomized control trials with drug-eluting stents. I'm not mentioning about bare metal stents. All of those have shown that there is improvement in mortality, and there is improvement in MACE, and as well as stent thrombosis after drug-eluting stents if they are inserted under IVUS guidance. However, the most important thing is the 3 questions I would always ask. First one is proper image acquisition, whether it's OCT or IVUS, right? Accurate image interpretation, which requires images to be acquired properly. And the third thing is correct decision-making based on the accurate image interpretation. So I think, in my opinion, unless and until you fulfill these 3 requirements, you may not be able to contribute in improving outcome under IVUS guidance. So that's why there's no point in putting a catheter, either OCT or IVUS, and then you could say that I've done in imaging. Unfortunately, I think this study will be coming. There aren't any studies, any randomized control trial of OCT or OFDI, which shows reduction in MACE once you perform stenting. And so I think from that point of view, image interpretation, image acquisition, people feel shy while doing imaging, you know, and there's only still 20% uptake of imaging in United Kingdom, you know, and one of the problem is that if you do not do enough imaging, then you're always going to think, you know, oh, I will just bang a stent in and walk out of the cath lab. So I think that attitude should not be there, you know.
I mean, it's not only that, it's, I mean, you've been generous there. I think it's something like 10% if you look at the last data set from the UK. But, you know, in certain other countries like Japan, where it's, you know, reimbursed, they have 100% imaging, don't they? So I think reimbursement also has a part to play, doesn't it?
So, Hale, I think 2 words, time and money.
Yeah.
The training, it comes when you do it, you will learn it. You will learn it. The most people who say that we don't know how to interpret it, they haven't done enough. The persons who have done enough, they will not have any problem in interpreting it. I think, yes, data limited, data are coming. Lumen 4, I think, will be very illuminating, but I think it's the time and money. If I can, if some places where the money is not a problem and they can do 10 stenting in a day as opposed to 6 with imaging guiding, they don't feel it's time effective. And in some places where it's the money that's a constraint, that's the issue. And I'm sure you have been to the centers. I have visited the places where there is very high use of intracoronary imaging, and I learned from the person who was doing it about 90% PCI is OCT guided, and it becomes so quick, so slick that it doesn't take extra time. And in most of the cases, you will be able to make some changes in your decision making. And the question of why we don't see much improvement in outcomes, because current drug-eluting stents and dual antiplatelet therapy is so good that majority of people will probably be okay if you even haven't got 100% good outcome of your angioplasty. But it's not a matter of that. Yes, most of them will be okay. I think if you have used a good stent, you have used good antiplatelet therapy, and you have also used intracoronary imaging, then you would expect that it should be 100%. The stent thrombosis, which is already less than 1%, that will go further down and down. But to show the improvement in something which is now very rare, because we have got good stents, we have got good antiplatelet therapy, it's very difficult. That's why even for IVUS, we are talking about meta-analysis of thousands and thousands of patients. It's doing one RCT to show a clinical outcome would be very, very difficult, if not impossible.
I think we do have to acknowledge that there are certain lesions that we treat where IVUS has been shown to be beneficial, particularly left main stems. You know, there's a wealth of data now showing that in left main stem disease, if you use IVUS, you will have a much better outcome. And this is not just target vessel revascularization or target vessel failure that we're preventing, it's actually death and stent thrombosis. So I think, you know, in those situations, I think it's mandatory. But even then, if you look at the data set from the UK, IVUS is only used in around 50 to 60% of cases for left main stem. This is specifically for left main.
Yeah, I totally agree. I think some of the centers, some of the ICs, they perform more IVUS and OCTs compared to some centers, you know. And I think majority of the centers, they do have IVUS available. And there's no question of reimbursement. Once the IVUS catheter is there, open it and use it. Similarly, if the OCT catheter is there, just use it. I think the basic rule of thumb, what I follow, because our imaging, particularly my own practice, is much higher than some of the other interventional cardiologists. And because I was trained in America, and especially after working with Gary Mins and the other guys over there, and their imaging usage at that time, I'm talking about several years ago, was over 90%. And still, that is the highest volume IVUS an imaging center in the world, you know, and because they are not bothered about even if the reimbursement in America of the IVUS and OCT catheter has gone down, you know. The most important thing is clinically, what you get out of imaging is of enormous value. Not only the shorter term, but the longer, even 1 year outcome after IVUS guided or imaging guiding stenting is showing much better results. For example, this Korean study, which is called IVUS XPL, 1,400 patients, 21 centers, you know, randomized 1-to-1 with angiography versus and 2.5% MACE in IVUS guidance, 5.9% MACE in angiography guidance with a p-value of 0.0007. So that is no brainer, you know, that we should obviously use the imaging wherever we can in majority of the circumstances.
Maybe I can bring Shazia in and get some of her experience. You know, when would you use OCT over IVUS, or you've already mentioned that IVUS is your preferred intracoronary imaging modality, but are there situations where you would consider using OCT over IVUS?
I mean, my main thing, which I think has probably been alluded to in the talks, is really to look at mechanism of stent failure. So essentially stent thrombosis or ISR, because that's one area where you do need the detailed high resolution images to look at the mechanism in order, if you want to prevent further recurrences. And I'm actually going to throw back a question to everybody now. So a lot of labs are limited in terms of what imaging modality. So going through the panel, if you had a choice, IVUS or OCT, you could only have one, which one would it be? I'll go to the Javeds first.
So sorry, is it me or the other Javed?
Both of you can answer first.
In terms of, I personally think it's not IVUS versus OCT, right? Although there are clear differences between the two technologies, resolution and surface details, I call it, favors OCT, but penetration and media to media sizing favors IVUS. Fine details again favors OCT, and the bulk of the data favors IVUS. And the better questions are not IVUS or OCT, is it IVUS and OCT versus angiography? We are very lucky, we got OCT, OFDI, HD IVUS, and all modalities of imaging. So I think I would suggest that both modalities are complementary, and non-left main lesions should be obviously imaged with OCT or OFDI, which I use quite a lot, and the left main lesion, obviously IVUS. That is the basic rule I use.
Yeah, no, I mean, the question was more really for those, they do both have their advantages, was more for those labs which are limited and can only have one.
I think most of the UK labs where they are properly doing intervention will have probably both. I can understand. I mean, maybe there's some
I'm talking
centers
more
in
about
Pakistan may not have it. I think, as I said, that I use OCT most of the time. But if I have to answer your question, I will go for IVUS.
Thank you. It's more really to those labs, maybe say in Pakistan and in the developing countries where they can only have one and have to choose one or the other.
That's what I'm saying. I will go for IVUS or probably HD IVUS if available rather than OCT. But as I said, that these are complementary techniques. There are some situations where, for example, if you're wanting to do the IVUS, if you want to do for the left main, I think IVUS is definitely better. But if you want to do, for example, plaque morphology, you have an area of uncertainty in the vessel, whether it's diagnostic or whether it's post-PCI, the IVUS is not going to be as good.
Can I also mention one important development, which is hopefully within maybe about 12 months or maybe longer, there is going to be a single catheter which will have both OCT and IVUS transducers, and you do not have to buy both modalities of imaging. And that once that is available, it means that that particular type of OCT or OFDI is going to be non-blood clearing method, which means that you push the catheter, and wherever you want to switch on to do IVUS, you will do IVUS. Wherever you want to switch on to do OCT, you will do OCT.
But if
have
you're
you
talking
put
about the
your
labs who
order
can't
in then?
afford both of them, then they will never be able to afford these ones. I mean, the hybrid imaging is very interesting. There are plenty of things coming, nurse with IVUS, nurse with OCT, and to look at different things. But again, the cost will be prohibitive, at least in the beginning.
500 pounds per catheter, Javed.
Okay, so maybe we should just sort of wrap this up. It's getting to the end now. So just want to give a warm thanks to both of the Javed, so Professor Ahmed and Javed Iqbal, for their excellent overview of IVUS and OCT, and also to the co-hosts this evening. So Shazia from Leicester, and Farhan, who's currently a local consultant up in Newcastle, and of course also to Ahmed for putting this all together, and the technical team as well. So I think we've had a good overview. I'm going to just give the final word to Ahmed. So do you want to just take over? So thanks, everyone.
No, you can conclude the session, Phil.
Okay, so just to remind you, it'd be great to have the feedback from everyone in terms of what they got out of the session, if there's any way we can improve the sessions going forward. So we'd love to hear from you about that. As you can see on the screen, there is another session which is coming up on the diagnosis and management of COVID-19. This is scheduled for Saturday, the 17th of July. So it's an open session. It's going to last an hour. We've got Dr. Munawar, who's going to give us an overview of COVID-19. He's got a lot of experience as a pulmonologist up at Lancashire and Preston. So we're certainly looking forward to that. And thanks to all the participants for their questions during the session. So I think we'll just wrap it up there. So thank you, everyone.